Yes, I have made co-host, sir.
Okay. Can you hear my voice clearly?
Yes, sir, I'm able to hear it loud and clear.
Okay. Okay. So are you able to see my screen?
Yes, sir, I was able to see it, but now it's disappeared again.
सिर्फ मेरे ज्वाइन की है
Are you able to see now?
Yes, sir, I'm able to see them.
Okay, that's good.
Shall we start, sir?
Yeah. If you say so, I'm waiting for your green signal.
Yes, sir, we can start, sir. So, good evening, everyone. We are very happy to welcome Professor Dr. Ravi Kanojia, sir, here today. Sir is professor at the Department of Pediatric Surgery at PGI Chandigarh. So, for today's lecture on IAPS NextGen, sir has agreed to do a lecture on anatomy and physiology of normal anorectum and correlation with anorectal anomalies. About Sir, Sir is an avid laparoscopic and robotic surgeon with the first neonatal robotic surgery done in India in the 2019 for a 2.5 kg baby of esophageal atresia. Sir has numerous publications to his name, and he has authored the book Thoracoscopic Repair of Esophageal Atresia, which has been published by Springer. Once again, a very warm welcome to you, sir. Over to you.
Okay. Thank you. Thank you so much for the generous introduction. I hope my voice is clearer. So,
Yes, sir, it's clear.
okay. So is somebody recording this as well?
Yes, sir, it's recording, sir.
Okay. So, when I was asked about taking this lecture for our postgraduates and the MCH trainees, I felt that we should always talk more about the basics, which is very, very rare now these days. And we deal with so much of reconstruction, and there is so much of anatomy and physiology involved, which we have to restore in our children to normalcy. And it is very difficult to understand with these anomalies that what was normal first. So I always insist with my residents that whenever they are learning about certain congenital anomalies, they should know that what is normal first. So whether it is the rectum, whether it is the esophagus, whether it is any other structure in the body, you have to know the normal anatomy, the way it is designed to be, and then only once you go and correct those anomalies by your surgery, then only you will be able to correct them towards normalcy. So you cannot do anything of your own. What you have to do is to replicate the entire thing the way the nature has intended to it to be. So that is why I decided on this lecture that we do a lot of anorectal anomalies in our children. It is, I mean, even nationwide, the highest load of patients in any pediatric surgery department would be with the ARM patients, both the male ARM as well as the female ARM. They come in a wide spectrum of anomalies where there are different kind of aberrations and different kind of anatomical disruptions which are happening. And then with your stage surgeries or single stage surgeries, you are supposed to restore to normalcy. So you cannot do that without knowing the normal anatomy and physiology of the normal anorectum. So this lecture is intended towards describing that part. So within the scope of this lecture today, we will try to define the anatomy of the anorectum in relation to the continence. So it is not like an anatomy lecture. It is sort of a clinical anatomy which is relevant to the system of continence which is designed inside our body, and then we have to replicate them in our ARM patients. There is always an associated physiology along with the neural aberrations which happen in ARM patients. And then whenever we do PSARPs, abdominal PSARP, laparoscopic through procedures in these patients, we see a certain type of anatomy within that scope of our operation. And then if you don't understand what structures you are seeing during that procedure of posterior sagittal anorectoplasty, you will not be able to create a good and anatomically normal anorectum and do your pull through procedures. So we will describe that what do we see during a PSARP, what are the muscles that we see, what are the muscles that we are supposed to cut, and how to look for the fistula and other things. We will describe it in relation to the anatomy. So as I said, to understand what is abnormal, one has to know what is normal first. You cannot skip this particular step irrespective of the organ involved. So anorectal anatomy is, I will take you back to your anatomy diagrams and anatomy, the Gray's textbook of anatomy. These diagrams are from that book, where we see the rectum as a hindgut termination, which starts opposite to the sacral promontory. So the beginning of the rectum is at the level of sacral promontory, and there are hausturations which are present in the colon. The hausturations are present in the anorectal area, the rectum which is there, and then the tinea which is present in the colon proximally, the descending colon or the transverse colon which we see, that tinea gradually merges or converges to form a longitudinal muscle coat, which is the outer muscle coat of the rectum. The middle part of that rectum is the dilated ampulla with mucosal valves. These valves are not actually valves, they are just mucosal folds. Because once you say a valve, you think of something like a flap which moves back and forth like you see in the heart structures. But this is not that kind of flap. It is just an angulation or indentation in the mucosa. We will talk more about this and their contribution to the system of continence once we go in the later part of this presentation. And then it has got an angle of 120 degree, which is absolutely important for the system of continence. You can see that the long axis of the lower part of the rectum and then the entire anal canal which is there, it creates an angle of 120 degree, and this angulation is very, very important. You need to understand when you do your pull through procedures, you just pull the rectum straight down to the neo-anus position, and then everything is straight from top to bottom, which in itself is a negative factor for the future continence in these children, and this is something very, very difficult to restore. So whether it is the pull through in Hirschsprung's, whether it is pull through in anorectal malformation, whenever you do a pull through, this angle is actually lost. So you have lost one component of the continence system which nature had created. So if you think the continence system as a wheel, and then this wheel will have four important spokes, which are the four important components of the entire continence system. So this figure is very, very important. It should be etched in your brains that these are the four important components. The first and foremost and the most important component is the striated muscle complex. I'm sure you must have heard this term from many of your seniors and senior professors. They use this term striated muscle complex. I would define in the subsequent slides that what exactly do you mean by the word muscle complex. There is internal sphincter, which is the second spoke, the perineal body, anorectal angle, which I pointed out before, the dilated rectal ampulla and the mucosal valves. They form another component of this spoke of this wheel of continence. And then in the last, the last important component is the neural innervation of these structures. Because even if you have a normal anatomy, but if the neural innervation is absent or is defective, then it will result into incontinence. So you'll have to keep this in mind. These are the four important spokes. I will take up all four of them one by one and then describe the finer details with these components. So let us start with this striated muscle complex, which is the most dominant and the most important part of the entire continence system. So this is the first scope, which is called as the striated muscle complex. Now muscle, since it is termed as muscle complex, it is made of several muscles. It is implied in the terminology itself. And the most important muscle which forms a part of this striated muscle complex is the levator ani muscle. And then the external sphincter, which is there, is also a part of this striated muscle complex. So this striated muscle complex is a sum of levator ani plus the external sphincter. This is depicted in this particular diagram, where you have the pelvic diaphragm formed by the levator ani muscle, and then it is like a funnel where the lower part of the funnel is the vertical stem of the funnel is formed by the external sphincter complex. So these two muscles brought together are called as the striated muscle complex. The most important thing to note is that these are voluntary muscles under the human control. So you can like sort of contract and release them as per your voluntary wishes. We will talk about these more in the subsequent slides. So now let us talk about the levator ani muscle, which is the most crucial muscle. So levator ani muscle or the levator complex itself is actually not one single muscle. It is made up of three striated muscles, which is the puborectalis muscle. Puborectalis muscle is shown in one, I will show it in one of the diagrams, the pubococcygeus muscle and the iliococcygeus muscle. So all these muscles are actually inserted into the inner pelvic brim of the bony pelvis, and then it will form a sort of a trampoline like diaphragm within the pelvis, and it will surround the structures, important structures such as the rectum which passes through it, and plus also the urogenital structures. So what the puborectalis will do, it acts as a sling. So it is you can see in this diagram that this red muscle is the puborectalis muscle, which is going around the rectum as a sling, and this sling is depicted here in this diagram, and you can see that it is this muscle which produces that acute angulation between the long axis of the rectum and the long axis of the anal canal. And this muscle can actually, once it contracts, you can completely shut the lumen of the anorectum and produce continence by voluntary contraction of these muscles. And it will also elevate and straighten and steady and suspend the rectum and act as a support structure. So these are also helped by the perineal body in the suspending action. We will talk about the perineal body again in the next few slides. So I hope you will have to create a mental picture of the origin and insertion of the puborectalis muscle. So this can be more clarified by this diagram, where you can see that, as I said, this puborectalis muscle, when it is seen in a 3D space, you can see that it is attached to the inner brim of the entire pelvic fossa which is there. So this is further clarified that we often draw the PC line on the invertograms on the X-rays, where you are supposed to determine the level of the rectal pouch in relation to this PC line. Now, what exactly is this PC line? Why did we had the need to invent the PC line? Because it's a specific landmark where the levator ani muscle is inserted. This line is actually not a line. It is, since we view it on an X-ray, it's a 2D picture, so it will form a line. But if it is viewed in a 3D space, it is actually a circle. You can see. So if you view this circle exactly at the level and the circle, it's like looking at a coin and holding it perfectly flat in front of the eye, and then it will appear as a straight line to you. But PC line is not a line. It is actually a structure which represents the insertion of the entire levator ani muscle along the inner brim of the pelvis, and it represents the level of the pelvic floor. Now this pelvic floor is the entire levator muscle is not a flat sheet. It is not like a flat piece of paper or a flat disc which is attached to the brim of the pelvis. It is actually a funnel like structure where the central part will be at a lower level, whereas the attached part to the bone is at a higher level. This is where the eye line is drawn. The PC line represents the attachment of the levator ani muscle along the inner brim, and the eye line represents the bottommost part or the center part of the levator ani muscle, where the rectum passes through the levator ani diaphragm. So I brought this PC line slide in this particular anatomy lecture because it gives an idea and a concept about the basic structure of the levator ani muscle, which is the key component of the continence system. And this is what decides the high, intermediate, and the low level of ARM. And this is how it helps you to understand the prognostic relation of the high, intermediate, and low. Because once the rectum in the low ARM anomaly, the rectum has passed through the normal location, through the normal space, and gone down towards the normal site, they will have better continence because their puborectalis muscle and the entire levator complex is quite well developed. as opposed to other patients who are high air anomaly and the rectal pouch is above the level of the levator ani diaphragm, and you are supposed to bring it through the opening in the levator muscles and then do a anoplasty. Obviously, they will have problems if the centering of that path is not done with these patients, then the continence will be affected. So this is how the concept of PC line is very, very important to understand in relation to the anatomical origin of the levator muscle. So this PC line represents that. So I'll again bring back you to this diagram to reiterate the entire anatomy of the levator ani muscle. It is made up of three muscles: pubococcygeus, iliococcygeus, and the puborectalis muscle. The puborectalis muscle is the innermost muscle. The pubococcygeus is the middle one, and the iliococcygeus is the outermost one. There are small fibers of coccygeus which are often seen as a one muscle rather than two separate muscles, as it is shown in the diaphragm. So this entire thing is actually the dominant part of the striated muscle complex, which is voluntary in nature. It is a striated muscle complex. So we know the difference between smooth muscles and striated muscles. Smooth muscles you cannot contract with your own will. Striated muscles are the ones which you contract. So they are just like as any other skeletal muscle, and they are very important for the continence of this system. Now, coming to the second part of the levator of the striated muscle complex, which is the external sphincter. Now, external sphincter is a very ill understood, muscle which is there. It is actually present in three parts and has got different configuration in males and another different kind of configuration in females. So what this external sphincter has got, it is a special kind of striated muscle which is called as the slow twitch muscle. Slow twitch muscle is which is resistant to fatigue. So we all know there are two kinds of athletes. One are marathon runners and the others are sprinters. So the marathon runners can actually run very, very long distances and they will not get tired. So they are the one who develop more of type 1 or the red fibers of the skeletal muscle, which are very, very resistant to fatigue as compared to the sprinters who have got the type 2A and type 2B. If you read about the type of skeletal muscle, you will know that they are type 1 and type 2A and type 2B. So the sprinters will have the type 2 variants and the marathon runners will be. So the external sphincter is that kind of muscle which is resistant to fatigue, and you can keep it contracted with your voluntary control for very long time, and you will not feel fatigue as long as you keep it contracted. So this is present in an arrangement which is called as the triple loop system, where there are loops of muscle fibers which are wrapped around the anal canal, and with this kind of loops going around. So these diagrams are depicting, these are from the Hall-Schneider book. So these diagrams are, this is in the male patient and this is in the female patient, where these loops are attached. So this difference in anatomy between the kind of loops which you can see that it is merging in the front part and it is divergent in the posterior part is because of the difference in the female anatomy between the bladder and the rectum, which is brought about because of the presence of the vagina and the uterus. So here it is converging over here. The basic need to understand is that you'll have to reconstruct these muscles and see them as you cut while you're doing a female PSARP, while you're doing a male PSARP, and again ASARP will show you a different kind of anatomy. So you need to understand the exact configuration of the external sphincter which is there. So as I said, the striated muscle is a triple loop system where it will have a subcutaneous part, a superficial part, and the deep part. So the deep part is actually contiguous and it merges with the levator ani muscle in a fashion of like a funnel. So if you see a funnel will have a upper part which is the wider part, and then there is a vertical stem. So that vertical stem part is actually the external sphincter, and the upper part is the levator ani diaphragm itself. So I'll show you the diagram before which I showed you earlier, that here you can see that this is the external sphincter which is merging up with the levator ani diaphragm. These fibers which you will be very able, if you are aware of the anatomy, you will be able to see this during your PSARP procedure. So you need to understand this kind of triple loop configuration. The subcutaneous portion is the muscle which causes the anal puckering. So you see a anal opening or the anal verge in a normal child when you do a per rectal examination for some other reasons. In a non-ARM patient, you will see that the anus is actually puckered and it is pulled inside or drawn inside. It's not, in order to expose the anal mucosa, you have to separate the buttocks. So that pulling is done by the subcutaneous portion of the external sphincter. Then there is the superficial portion, and then there is the deep portion, which is contiguous with the puborectalis muscle, and the whole thing suspends and holds the anal canal, like a funnel, and it can actually shut close the lumen of the anal canal, and then you can do that voluntarily. So I hope this part is clear, where the striated muscle complex is formed by the two major components, out of which levator complex is the bigger component, and then this external sphincter is the smaller component. So now we talk about the second spoke of the continence system, which is the internal anal sphincter or internal smooth muscle complex. So this is now not a striated muscle complex, this is a smooth muscle complex, which we will describe. So this is the second spoke. The internal sphincter, we all know, is a continuation of the longitudinal layer, which of the circular layer of the rectum and the colon, which comes above, and it becomes thickened in the lower part and around the anal canal. It is sort of a teardrop fashion, which you can see over here. And now this muscle is very special because it is a smooth muscle. It can stay in a tonic contraction state even without you knowing that it is lying in a contracted state. And this is the muscle which if there is a rectal distension is happening, it will relax in response as a reflux, as a sensory reflux. It will relax in response to the rectal distension, which will lead to passage of either air or some liquid or some solid fecal material coming to the anal canal. It will touch the sensors in the dentate line, and the anal canal will be able to sample the contents, and based on the sampling of contents, you will be able to relax your external sphincter and release either air or the solid fecal matter, depending upon the social situation. So you can understand the whole sequence which is happening in this whole complex sensory reflex system, that whenever there is a rectal distension, the internal anal sphincter will relax and will cause the opening of the anal canal. And once the anal canal is open and some material is going to drop down from the rectum towards the dentate line, the dentate line has got specific sensory corpuscles over there. I will describe in the next few slides, and then you are able to sample it. So this is known as the rare response on manometry, which is done for Hirschsprung's disease. It is absent in patients of Hirschsprung's disease. So knowing this will help you to understand the rare reflux which is happening in Hirschsprung's patients, because in Hirschsprung's, because of the ganglion problem, this internal anal sphincter is in a tonic state of contraction and causes the rectum to shut close even with the distension of the rectum. And this is it is this absence of rare reflux which is diagnostic of Hirschsprung's disease in these patients. So now you can correlate the rare reflux in relation to the anatomy of the internal anal sphincter. So this was the second component. Now, this is a infographic which I made from ChatGPT. I described the entire prompt, and whatever I was talking, I wrote the entire concept, and then it came up with a really impressive thing. I want to bring in a little bit of a physiological explanation of what happens in Hirschsprung disease and connect it with the anatomy of these internal anal sphincter and the external anal sphincter and the rare reflux. So you can see that, as I said, that internal anal sphincter is a non-fatigable smooth muscles, which means that it can stay contracted without getting any kind of fatigue. And in basal state, it is in a state of tonic contraction. It generates a very high pressured zone in the lower rectum, which is obvious when you do anorectal manometry. And this high pressured zone will drop as soon as there is rectal distension, which you either do by a balloon distension of the rectum or by giving enema or by gentle finger stimulation, which can do, and then it relaxes in relation to that and allows sampling of the rectal contents without the loss of. So once the material comes into anal canal, the external sphincter is still keeping that thing closed, but it has opened it up a little bit because now the internal anal sphincter has relaxed and there are contents. So if the social situation is there that okay, you can go to a toilet, the child can go to a toilet, then he will relax his external sphincter also, and the process of defecation is going to get completed. Now what happens in Hirschsprung's disease, that the autonomic nervous system within this entire area of anorectum, right, even including the colon, sometimes for long segment Hirschsprung disease, there is a sympathetic overdrive and a lack of parasympathetic excitatory input. So what happens is that the tonic contraction state is actually dominated, and the parasympathetic system, the ganglion cells which are supposed to fire and give the parasympathetic influence into the walls of the anorectum, is absent over there, because the ganglion cells have not developed. There are immature ganglion cells. The entire neural trunks, there are hypertrophied nerve trunks which are not able to propagate the impulses, so that will be absent. And then even with the rectal distension, the internal anal sphincter is not going to relax, and then the entire anorectum, including the lower part of the rectum for short segment Hirschsprung disease, it will remain tonically contracted, and then it will result into functional obstruction. So despite being physically patent, the lumen being physically patent, there will be obstruction to the flow of the fecal matter because of the tonic contraction, and this happens because of the sympathetic overdrive. We will talk about the nervous system of these parts in one of the few slides, and then try to understand and then correlate it with the rare response. So this slide is little, there's too much of content, but once you read it, you will be able to understand both the relevance of the internal sphincter in relation to the anorectal anatomy and the continence system, and in relation to the Hirschsprung's disease, that how it is important and how it affects the entire disease process. So of all the so we have, out of the 4 spokes that I described in the graphic earlier, I have now described 2 parts of it, which is the striated muscle complex and the smooth muscle complex. The striated muscle complex was the puborectalis plus the external sphincter, and then the internal sphincter, which is the smooth muscle complex. So if the total intrarectal pressure is around 30 mg, the puborectalis or the striated muscle complex is going to contribute 20, which is almost like 70% of the entire pressure which is generated, and then the internal sphincter will produce 30% or 10 out of 30 for the pressure that is present inside the anorectal canal. So now you can imagine, in a patient with ARM who has got deficient external sphincter, who has got deficient internal sphincter, only puborectalis muscle is present. So out of this 30 mm of Hg, the normal pressure which should be present in the system, he would barely have like 8 or 10, which is contributed by the puborectalis muscle. So you can understand the relevance of each of these continent. So one more thing to point out is that continence during sleep and rest is by the continuous tonic contraction of the internal sphincter, as I said. So even if you don't know, you don't realize, your internal sphincter is working, and then if the child is awake and he's crying, he's squeezing, he's coughing, then the continence during raised abdominal pressure is contributed by the levator ani and the external sphincter. So this is the reason, so that some of these children, even after restoration of the normal anatomy of the anorectum, because they have weaker muscles, because they don't have the internal sphincter after a pull-through procedure, they will have leak accidents with coughing, sneezing, and anything which increases their intra-abdominal pressure, which is a very, very common complaint in these patients in the OPD follow-up visits. So now out of the 4, we'll come to the third one, which is the perineal body, which it's a group of factors which are present in the rectum. Perineal body is one, and the anorectal angle I spoke about in the earlier part, rectal ampulla, and the mucosal valve. So now perineal body is actually a very, very ill understood anatomical component which you see during either PSARP or ASARP. You don't see it during PSARP, but you definitely see it during ASARP. And it is very, very important to know what are the attachment, what it does, and why do you need to repair it if it is disrupted. One of the examples of the importance of perineal body is incontinence in women undergoing episiotomy procedure. So what happens is that the baby is getting delivered, the head is coming out, the introital opening is not big enough for the head of the baby to pass. Then the gynecologist is going to give a episiotomy. She will put one blade of the scissor inside the lumen of the vagina and the other outside and just cut. Once they do that, they actually disrupt the perineal body. If you don't repair the perineal body, the woman is going to be incontinent in future. If not total incontinent, she would be like 60-70% incontinent, because she still has the levator ani and the internal anal sphincter in a normal state. So, or if they are repaired badly, or they have too much of scarring because of infection of the episiotomy, the perineal body is going to get disrupted, and it will result into sort of an incontinence. So perineal body is made up of 4 muscles, out of which 2 are paired and 2 are unpaired. So the ones which are coming transversely are the superficial and the deep transverse perineae, and then the arching fiber of the puborectalis muscle along with the external anal sphincter are going to converge into a central tendinous area, and then the arching fiber of the bulbocavernosus muscle. So this central tendon part will form the perineal body. It's kind of a center of gravity of the human perineum, if you want to understand it in that way. So a lot of things are converging, a lot of things are decussating in that particular spot, and you need to restore it to normal. The other components within this third component are the anorectal angle. As I said, the anorectal angle is almost like 90°, which is lost after pull-through procedures. Rectal ampulla is nothing but there are no specific valves, but they are just folds of big folds of mucosa which actually hold down a falling. So you must have seen a game where a ball is dropped and there are multiple shelves and the ball goes zigzag, and the fall of the ball is actually slowed because of the side projecting obstacles. So it's like you can imagine that a ball of fecal matter is dropping, it will hit here, it will get slowed down, it will again hit here, it will slow down, then again it will hit here, it will slow down, instead of just dropping from top to bottom and then coming out. So these are minor components, small things to have, but very, very important. Okay, so this is anorectal angle. Sometimes we need to understand that you can still have anorectal angle to certain extent in intermediate and low anomalies, but if you do a bad colostomy means that the colostomy is in a lower location, and the segment of rectum from the colostomy to the fistula site is very, very small. You do a very, very tight pull through, that rectum is going to be extremely straight, and then you will lose this angle. So another reason to do a good sighting of colostomy is to have a good length of colon distal to the stoma, so that when you pull it down, it is not a perfectly straight line pull through, and you can have some amount of anorectal angle in these patients. So we spoke about the three components: striated muscle complex, internal sphincter, perineal body, and the miscellaneous components. We come to the fourth one, which is the neural organization of the anorectum and sphincters. So as I said, even if you have everything normal in patients with spina bifida patients, if everything is normal, they have normal levator ani muscle, they have normal anorectum, there is no structural disorganization. Only thing they lack is that they don't have a proper neural innervation. The same thing will happen if there is a spinal agenesis or sacral agenesis in these patients. We all know that patients of ARM will have sacral agenesis, and if they have sacral agenesis, their prognosis in terms of continence is very, very poor. Even after best of the best pull-through procedures, or even after the best of the best levator ani and the external sphincter, you give them or reconstruct them, if the nerves are absent, it is very, very difficult. So the control of neural system comes from the S1, 2, 3, 4, which is via 3 nerves, very important nerves: pudendal nerve, the superior hypogastric plexus nerves, and the nervi argentis. The sympathetic is coming from the hypogastric plexus, and the nervi erigentis is the parasympathetic one. This is the one which is going to go and innervate the internal sphincter complex, and it will cause that tonic contraction because of the absence of the parasympathetic impulse. So if S234 is inactive, then which happens in Hirschsprung's patients, there will be a sympathetic overdrive in these patients, and then it will lead to a tonic state of contraction. So the entire gear which moves the somatic innervation and the autonomic innervation is the S234. So if there is sacral agenesis of S4, you will have less problems. If you have sacral agenesis of 3 vertebrae, you will have more problems. So this is a direct correlation with the level of continence or the level of incontinence these patients will have, and you will have to be. But the sad part is that you cannot, if these are absent, you really cannot do anything except for restoring the anatomy as much as you can, so that at least whatever nerves which are there, whatever the rectum which is passing through a correct track in the levator ani muscle, the patient might be able to contract the levator ani muscle by the use of pudendal nerve, by the use of future neuromodulation physiotherapy techniques, and he will have some amount of continence. But nerves are things which you really cannot create. So now with this, all 4 spokes of continence, where we looked at the straightened muscle complex, smooth muscle complex, the accessory structures for continence, and the neural structures, the entire continence is regulated by a lot of reflexes and a lot of physiological things which happen in the presence of these normal structures. So sensory reflex is one, motor reflex is one, and there are certain unique properties of the rectum itself which helps in the continence system. So what is the sensory reflex? It is the same rare reflex which I enumerated before, where the rectal distension produces the reflex, either a reflex contraction or a reflex dilatation or a reflex relaxation of the internal anal sphincter, and then a subsequent relaxation of the external sphincter depending upon the will of the individual. And then another kind of sensory reflex is regulated by the fine proprioceptive receptors which are present around the dentate line. So we lose the dentate line in any of these ARM patients, but the dentate line is very, very important. If you destroy all the receptors around, this is the reason why a lot of people say that the fistula site should be preserved when you're doing a pull-through procedures as much as you can. Because it is the region where all these fine proprioceptive reflexes generating sensors are present, which will help you discriminate between gas versus solid fecal matter. So the mucosa over the dentate line contains these nerve endings which are responsible to give the sense of pain, Missinner's corpuscles. I'm sure this is, if you go back and read your Ganong textbook of physiology, you will again come across these names, the Croce end organs for pressure and the Pacini corpuscles for friction. These are very, very important to have, because as a normal individual, since you have them, you have the ability to pass gas yet restrict the solid fecal matter, which is a very, very important part of continence system. So we are all blessed with this kind of system where we can release gas without releasing the solid fecal matter, as compared to ARM patients or pull-through patients who they will know that they are about to pass gas, but once they do that, they will have an accident and fecal matter is also going to come along with it, because their system is deficient and it is not able to discriminate between air and the fecal matter. So the motor reflex is the tonic contraction of the internal anal sphincter, which is the normal physiological state. And then there is the reflex contraction of the levator ani and the external sphincter in relation to the distension of the rectum. So whenever in the morning time, when your rectum is full and distended and you are still not ready to go to the toilet, your levator ani and the external sphincter are going to so although your internal sphincter is still relaxed because of the distension of the rectum, your rest of the other striated muscle complex is trying to keep it shut, because you are not yet ready to go for the toilet. You will go when you want to go. Somebody will have a cup of coffee, somebody will wait for a certain time. We have our own ways of dispensing in the morning. So this is that part of motor reflex which is absent in patients of ARM. Now the rectal ampulla or the entire rectum itself has got a lot of unique properties, where rectum is a part of colon actually, but it is different in kind of peristalsis the proximal colon will have, and the kind of peristalsis the rectum will have are vastly different. So the rectum can have low amplitude reverse peristalsis. The rectum, if there is fecal matter in the rectum, there is not enough opportunity of the individual to go to a toilet. He will keep it there, and then slowly the whole fecal matter is actually pushed upwards, and then he will do away with the urge of going to the toilet, because now the rectum has become empty. The rectum has designed itself in a way that it wants to stay empty rather than being full, which is called as the rectal adaptation. And then there is mass also isoperistaltic wave. A lot of times you have seen that the kids come and complain, parents complain that whenever he eats and whenever he has something, he will immediately want to go to the toilet. This is because this is a reflex situation where there are a lot of hyper intense isoperistaltic waves, which makes the child feel the urge to go to the toilet. So the entire defecation system works in a very synchronized manner, where if initiation is done by the voluntary abdominal contraction, or there is a gastrocolic reflex or a colonic reflux, or direct rectal mucosal stimulation or rectal distension. You can achieve this by giving enema in constipated individuals. So when you are giving enema in constipated individuals, one of the target is to distend the rectum, because that distension of the rectum is going to set a cascade of reflux events, which is going to result in either increased peristalsis in the rectum, relaxation of the sphincters, and then finally the procedure of defecation is going to happen. So as I said, so even a finger stimulation, if you do a PR, some children are going to pass, or put a suppository, they are going to pass. So the entire concept behind doing all those kind of maneuver is to stimulate the rectum or fill the rectum, and then it will lead to increased rectal pressure and stimulation of receptors in the pelvic floor. There will be a desire to defecate, and there is a relaxation of the internal sphincter. So till here we are on the rare reflux, which is present in normal individuals. And then if this up to this point, if the individual has the opportunity to go to a toilet, socially acceptable opportunity to go to a toilet, he will go and relax his external sphincter and relax his entire striated muscle complex, and the procedure of defecation is going to happen. However, if no social opportunity is present and he cannot go to a toilet, he will just shut close the anorectum with the external anal sphincter and the puborectalis muscle, and then the reverse slow amplitude peristalsis are going to happen in the rectum, and then they are going to push the entire fecal bulk back up into the upper part of the rectum, and rectal adaptation is going to happen, and then the whole cycle is going to then start again after some time, when there is another stimulus which is happening with the individual. So this is the same diagram which is showing. This is the bulk of fecal matter which is coming. Here the social opportunity is not present. The bulk is coming down. There is a relaxation of internal sphincter, but no opportunity present. The puborectalis and the internal anal sphincter will remain contracted. But if he is able to go to the toilet, the puborectalis and the external sphincter is going to relax, the bulk is going to come down, and he will be able to pass. And the levator and after he has passed, it will he will complete the defecation procedure. And once the defecation procedure is completed, the internal anal sphincter and the external anal sphincter are going to relax, and the rectum is going to contract again. Now here you can notice that both the internal sphincter and the external anal sphincter are relaxed, because now the rectum is empty, all the load has been disposed, and but we know that in a normal state, the internal anal sphincter should go back into its tonic state of contraction. So it will go back into tonic state of contraction, but after the completion of defecation, for some time, it will remain relaxed. So this is that, I'm sure you will correlate once you have a good bowel movement, you feel very relaxed in your perineum, you will feel relaxed you get a good feeling. This is happening. This feeling of content is happening because of the relaxation of the internal anal sphincter. It will go away after a few minutes, maybe 5-10 minutes, once the internal anal sphincter goes back to its tonic state of contraction. So I hope you can understand and correlate with your own body's physiology, that the feeling of content or the feeling of complete evacuation, the feeling of freshness that we say you get in the morning after completion of defecation is happening because of the relaxation of the internal anal sphincter. And this is not present in the ARM patients, so they don't get this. I'm sure you must have heard the word tenesmus. Tenesmus means it's a sensation of incomplete evacuation where the internal anal sphincter is actually going to close prematurely even when this bulk is uh, passed completely. So half of it is going to come out, the half is going to stay in. It is still wanting to come down, but the internal anal sphincter has gone back into a spasmic state and it is now closing the anal canal. This is where you will get that feeling that although you have passed some fecal matter, but still there is some remaining behind. The rectum is not empty, the pelvic muscles have not relaxed, the levator ani is not relaxed, and then you get that feeling of sensation of incomplete evacuation, which happens in constipated individuals. So that is a different topic where these individuals will have sort of a pseudo obstruction. Despite having everything normal, they will have this more of a tenesmus kind of completion. So now what happens in ARM patients? It's both structural as well as neural. So there is no anal canal in these patients because the rectum and the anal canal open as a fistula. The rectum is ending as a fistula. There is poor organization of the levator and the sphincter muscles. So now let us come to the anatomy that we see during PSARP, which is the basic target of this presentation. Because unless I give you the background of the entire normal anatomy, I will not be able to explain what you see over here and how are you supposed to reconstruct when you do a PSARP procedure. So this is a PSARP patient where we have just started the incision, and then you can see that we straight away come across, these are the transverse fibers. This is quite clear on my screen. I'm not sure how much it is clear on your screen, but you can see there is a vertical group of fibers and then there is a transverse group of fibers. We need to know what these fibers represent and how are they relevant to the position of the new anus that you will be reconstructing. So we haven't deepened the incision yet to reach the rectum. We have just given a superficial incision over here. And then, so what are these? These are just the part of the external sphincter. So again, we will come back to this diagram where this horizontal fibers are the superficial portion of the external sphincter, whereas the vertical fibers are the deep portion of the external anal sphincter. These vertical fibers are actually, you have to see it in a 3D image. A mental 3D image has to be created over here. So these fibers are going up and merging with the levator ani complex. So as you go and deepen, similarly over here, these horizontal fibers are actually the vertical stem of the funnel that I was describing, which is the striated muscle complex. So again, this is another picture drawn from the Pena's books. So this is the part which you have cut, and this you can see that there are some fibers which are drawn over here. So these are the parasagittal fibers. They are nothing but the superficial part of the external sphincter. You can see the same thing over here. The incision has deepened. So here the incision is very, very superficial. You can see the transverse fibers over here. But here the incision is deepened and reached up to the level where it is merging with the levator ani diaphragm or the levator ani muscle. Once you cut this muscle, along with that you will be able to see the rectum. So here you can see these are the same transverse fibers over here. The vertical part of the funnel which I am talking about, the entire striated muscle complex. So these are the fibers. So I hope you will have to create, you'll have to repeatedly see these diagrams again and again and try to visualize this as a 3D anatomy to to comprehend the organization of this entire levator complex which is seen during the PSARP procedure. So this is quite an accurate diagram over here where the levator ani is drawn. So this part is the levator ani. You can see the rectum has not yet traversed the levator ani muscle, and then it is merging as a funnel with the vertical part of the superficial muscle. So this entire thing is labeled as striated muscle complex, a term which is coined by Dr. Penna. So this is one of the diagrams from our patients, the actual patient. So this is the buttock patient is in a prone position, PSARP position, and you can see he's got a good buttock. He's a big child, and you can see some stigma of sort of a bucket handle which was done somewhere outside. So we'll just overlay the bony pelvis, the bottom view of the bony pelvis, just to anatomically make it accurate and give you a 3D picture of what is there. This is just a rectum which is lying behind in the midline. So it is lying deep inside, and then this is that striated muscle or the vertical part of the superficial part of the external sphincter which is come over here. So once I divide over here, I will be able to see this band of the transverse fibers of the external sphincter. And then this is the entire levator muscle which is deeper in the, so the rectum, this rectum is actually supposed to go behind this levator muscle, and once we cut the levator muscle over in the midline in continuation with the I don't know if I can annotate, see if I can annotate. Yeah, I can. I can. So once I cut over here, I will be able to see and expose the rectum, and this is what we see in the PSARP patient. So this is that same part which is visualized over here. Okay. So the correct position of anorectal plasty in PSARP. So the ARP in PSARP. So if you place the anorectum outside the bounds of this external sphincter or outside the lumen of the vertical part of the funnel, then the continence system is not going to work. The external striated muscle complex is not going to work because it will not be able to produce that sling-like action of the puborectalis muscle. So if you place it anywhere outside it, either here or here, the continence is going to be very, very poor. So the rectum opening should come within this vertical part or the transverse center part of the transverse arching fibers, which is the vertical stem of the funnel. So this is the most important point in relation to the anatomy when you do a PSARP, where to locate your anorectums. This is where we actually mark with silk sutures. So this thing is supposed to coincide with the the hyperpigmented area when you see before cutting the fibers. You will even use the muscle stimulator to contract these muscles. So these muscles are going to contract inwards. So once you stimulate them and touch the probe of the muscle stimulator, these are going to contract inwards, and then by those contraction, so sometimes these transverse fibers are very, very poorly developed and you see nothing visually. So the only way is to stimulate those muscles, and by the boundaries of the inward contraction of the muscle, you will be able to figure out the boundaries of your neoanus, and that's how you would want to put the neorectum right in the middle of this funnel. What happens to the perineal body in female ARM? So perineal body is there, it is well formed, but just because the entire thing is actually reversed. So the rectum ideally has to be supposed to be present over here. This is the rectum over here, and the perineal body is over here. So when you do an ASARP or PSARP, the perineal body is definitely going to be disrupted because you will have to cut through over here. And once you cut through, you will have to reapproximate the perineal body components. You may not be able to see the specific superficial and the deep transverse perineum. So you'll have to make a fair judgment of whatever muscular structures that you are seeing while repairing the anterior part of the anorectoplasty, and then you will approximate and create the perineal body. So what happens in ARM? Again, there are several problems from the neural point of view. First is that you don't have nerves, you may have missing sacral segments, you have absent neural monitoring receptors, the Pacini corpuscles and other receptors which are present in the dentate line. And then there is another problem that the entire sensory and the motor reflux is disorganized because the child has not defecated in the early part of his life, which is the crucial part, which is the brain learning or the cortical training, which is happening in normal individuals. It doesn't happen in these patients, and then again it forms a part of the incontinence system. So that is the reason why we say that the entire procedure or the steps of the ARM should be completed within 4 to 6 months of time, so that that first year of crucial training of the brain evoked cortical responses or the brain training is not missed by the child. Okay, so there are a lot of imaging modalities. Once you do a ARM, you need to see these muscles. If the child is not yet continent and there are problems with the child, so there are several modalities. You can do endoanal ultrasound, which will show the location of the muscles and the thickness of the muscles around the anal canal. And then you will be, if they are asymmetric on the other side, you can see either on ultrasound or on CT, which can even be done with an endoanal coil in bigger children, and you will be able to see, and then you can decide on the need of a redo procedure to put back the rectum into the central position. So to conclude, I think this has been a long lecture, but just to conclude that the entire anatomy, you have to thoroughly understand the four components of the spokes or the four spokes of the wheel of continence, which is the striated muscle complex, the smooth muscle complex, the accessory factors, which will include the anorectal angle, the perineal body, the mucosal valves, and the unique rectal properties. We try to retain them as far as possible. It is not always possible to retain all of them. And then the fourth component, which is the neural organization. So we need to preserve that. The way we can do better with the neural organization is not to like excessively devascularize the rectum during the pull-through procedure, preserve the vascularity, don't do too much of tissue burning, don't do too much of tension in these procedures, and then try to preserve whatever nerves which are present over there. And then you try to keep all these four components and give the child the best of the best chance in terms of continence. So you have to recognize all the four components and make best use of them. And so, as I said, I'm saying this repeatedly, that you have to be aware of this normal anatomy during the reconstruction procedure. If you don't know the normal anatomy, you will not be able to restore, or you will not be able to do the PSARP operation like a pro. And it has a good anorectal pull through, has got a huge bearing on the continence and the outcome. Because if you do at least PSARP is done correctly, there is one less problem for the patient, although he may be having several other problems which are not in your control. But at least whenever the child comes to you for an operation, he should not go away with added problems. He should have at least one less problem once he leaves the hospital. Otherwise, ARM is a very surgeon's role of ARM is like 60%, 40% is by the supportive care, the bowel management program, and the other, the parent support, the family support has to be there. And so we need to understand thoroughly over there. So this anorectal, I keep talking to my residents, and they will not know at times that what is perineal body and what are the muscles which are attached in the perineal body and what does it do. And they will not know what is the muscle that they are seeing and what is the relevance of those muscles that they are seeing. Nowadays we are doing laparoscopic anorectal pull through. So you are able to see the levator muscle from inside, from the other side. So in PSARP, you are seeing it from the back side. In the lap pull-through procedures, you are able to see, and actually you are able to get a very, very good view from the telescopic view, and you can actually dig into the most central part of the levator muscle. There are laparoscopic muscle simulators which can delineate or map the exact center point, and then you can create a tunnel on that center point and make the rectum pass through that central part of the levator muscle, and then give the best chance to. So you need to be aware of all these continence system and all the four spokes of continence, wheel of continence, and then only you will be able to do that. So with that, I will end my talk. If there are any questions or interactions or anything, any comment which you want to say, we can have a discussion if the time permits.
Thank you so much, sir, for this enlightening lecture. I'm sure I speak for all the residents in saying that this has opened up a very fresh perspective for all of us on the importance of the anatomy and physiology. Please do unmute yourselves to ask a doubt, or please do ask the doubts in the chat box.
So even if you have questions, if you are not able to put it here, you can send it to me on my phone or on my email. And so how to make 120-degree angle? So you cannot make it 120-degree angle. All you have to do is to make it pass through the central part of the levator muscle and then do the anoplasty right at the correct portion in the hyperpigmented area, or the area where I showed you the transverse muscle fiber, the exact location the new anus should be. Once you do that, I mean, you would have made the rectum pass through its normal course. If it is going through its normal course, it will have some angulation or the other. It may not have that 120-degree angle, but at least some angle will be there. So you cannot recreate what God has made. All you can get close to it, but not you cannot do 120-degree with any of the pull-through procedures.
So we have a doubt. How do we differentiate between anteriorly placed anus versus a perineal fistula versus ectopic anus?
So these terms are very actually ambiguous terms. I mean, they are very loosely applied to anything which is present, anal opening which is present away from the normal situation. So ectopic versus perineal fistula. Perineal fistula, I would say, are the ones which are present inside the vestibule or which are present inside the foreshead, posterior foreshead, rather than coming below the foreshead. So anything which is below the foreshead would be termed as an ectopic, anterior ectopic anus, and perineal fistula would be the one which is present immediately behind the vagina and which is present within the vestibule opening itself. So parasagittal fibers, importance of parasagittal fibers, as I said, it is the superficial part of the external sphincter. It is quite poorly developed in these patients of ARM, and they are basically anatomical landmarks and nothing else. So if you have equal bulk of parasagittal fibers on both sides of your incision, that means you are in midline and you are progressing correctly in the midline, rather than making your way towards the deeper part in a paramedian situation. So that it just gives you a visual cue that you are incising the PSARP incision exactly in the midline. Would a fistula in rectovestibular fistula have a defined dentate line? Most of these patients, they don't have a dentate line. Even if they have some sort of sensory corpuscles in that particular area, it is destroyed while mobilization, because most of the time that once you have disconnected the fistula and you have lengthened the rectum, the distal most part is basically ischemic, and you do most of the time do little bit of trimming, or even if you don't trim, you put it in the stitches, so everything gets squeezed in the stitches. So they would ultimately, be ischemic and destroyed, and those nerve endings are going to get killed. So this is the reason that you cannot restore that kind of anatomy, and dentate line cannot be there. And actually, this is the reason that why in pull-through procedures for Hirschsprung's disease, where you're doing a transanal pull-through, you are actually starting your circumferential submucosal dissection 0.5 centimeters above the dentate line and not at the dentate line. So just to preserve the anatomy of the dentate line. Posterior limit of the new anus is the transverse fibers, the one indicated in the image. Yes, so I showed you those three images where, so it is the entire breadth of those transverse fibers which is going like this, and then you place it in the center part. So Dr. Kanishka is saying, don't we reconstruct the perineal body after dissection is over in PSARP? Why do you say that we don't see it? No, I meant to say that the perineal body is most of the time divided and exposed in the ASARP procedures. In PSARP, we usually don't, the incision doesn't goes up to the perineal body, it stays intact. and you really don't need to reconstruct the perineal body in the male ARM patients.
So we have a doubt. In anterior ectopic anus, do we have to bring the rectum through the sphincter?
So in anterior ectopic anus, the rectum has already traveled the anorectal, the levator ani muscle, and then after it has exited the levator ani muscle, it turns forward, and instead of passing through the external sphincter, it goes forward and lies behind the posterior fourchette or somewhere in the perineal body region. So for that kind of thing, the anoplasty procedure that we do for low ARM patient, all you have to do is to mobilize that fistula and bring it back within the domain of the external sphincter muscle and then stitch it over there. Now, these patients, whatever you do and whatever, even the worst of the worst anoplasty you do, these patients are still going to be continent to a large extent because the rest of the apparatus is fine. The levator muscle is fine. The internal anal sphincter is also fine to a certain extent in these patients. It is only the small component. So as I said, the 30 mm pressure which was shown in the entire continence, intrarectal pressure which is there, it's only the 5 to 8 is contributed by the external sphincter.
Sir, excuse me, sir. I'm Dr. Arindam. I just want to ask you one question. While we are doing operation for anterior ectopic anus, how far deep we should go to bring it inside the external sphincter? Means how can I know if I am presented with a case with anterior ectopic anus while I am doing the operation? How far I should go deep so that I come to know that I have done enough to bring it inside the sphincter?
So the limit of mobilization of during anoplasty, I think that is your precise statement.
Yes, sir.
The
Yes, sir.
limit is actually defined by, once you mobilize, you see that how far it will reach down into the normal area, and then anterior to that you have to again reconstruct the perineal body. Okay, so in order to reconstruct the perineal body, the anorectum has to be separated from whatever structures that are present anterior to it. So
Okay.
that is an individual judgment during the surgical procedure. I will not be able to tell you a particular landmark, anatomical landmark, which I can say that, okay, you stop over here. It is just an individual judgment that you mobilize circumferentially and then bring it back to the normal position. You see that it reaches over there, and then anterior to it, you approximate whatever muscle that you see in front of it, so that a sling-like thing is created around that anoplasty, which it's sort of reconstructing that external sphincter muscle which is present, if it is present in that particular patient. So I cannot tell a specific end of dissection landmark for this anoplasty.
Yes, sir. Thank you. Thank you, sir.
So we have another doubt. How can we explain constipation in low ARM and fecal incontinence in high ARM?
Yeah, so as I said that in one of the slides, the unique rectal contractions or the ability to adapt. So in these patients, all those unique peristaltic activities which is supposed to be present in the rectum or the ampulla of the rectum is actually not there. So these patients will have constipation so even after a good anoplasty, the caliber is very good. You are able to do a good PR and the passage is perfectly patent. They may still have constipation because of inherent bowel motility reasons, because of the absence of these all rectal adaptation mechanisms. And then incontinence is happening. A lot of these incontinence in these patients are happening after it's sort of an overflow incontinence in these patients where they develop sort of constipation in the first phase, and then they start liquefying whatever material is present inside there, and then it starts dripping down and then becomes sort of an incontinent.
So Dr. Priyanka has asked us, what is the embryo-pathogenesis behind posteriorly placed rectoperineal fistula, which is placed just below coccyx?
Rectoperineal fistula, embryologic basis, very difficult to say. So I cannot comment on the rarities of the anorectal malformation. The embryology of ARM itself is a very ill understood and is a very, very long topic. So I really don't know the answer to that.
So we have another question from embryology, sir. Do we think the entire anorectal unit including the sphincter mechanism, is displaced anteriorly as a single unit, or is there a degree of mismatch between the anal canal and the muscle complex?
The anterior displacement is not a fault feature of the anorectal problem, the anorectal embryology. It is a feature in extrophy complex where the entire thing is anteriorly displaced. It does not happen in anorectal malformation patients. The basic issue in anorectal is it's actually a mesodermal defect. If you go back to the embryology of these patients, the mesoderm, which is supposed to burst out and then open up into the surface of the perineum, it does not happens, and then there is an abnormal communication. So there is a general rule in embryology that whenever there are two lumens developing parallel to each other, so whether it is the trachea or esophagus, whether it is the anorectum and the urogenital tract, if they are developing together side by side, they are not able to go and open onto the exterior, or something goes wrong, they produce a fistula with each other. This is the general rule of embryology. Why that happens, I really don't know. So same thing happens with the T fistulas also, where the esophagus and the trachea are developing. Probably they are developing from one single barrel or a tube which gets separated by sort of infoldings happening within that tube, and then they get separated. They are not separated. They ultimately end either having a common component or having a fistula. So that kind of thing happens. So embryology is very, very complex. It is very difficult to go into the details of embryology. So the purpose of today's lecture was to, you know, learn the normal anatomy, where you should know whatever the components of anatomy are there, what are the muscles which are there. A lot of terms which are used interchangeably by seniors and consultants and the students. The striated muscle complex, smooth muscle complex. So we really don't, when you say striated muscle complex, the student doesn't really have a clear picture in his head that, okay, striated muscle complex means levator plus external sphincter, and smooth muscle complex means the internal anal sphincter. So once that term is thrown towards you, you should immediately, these pictures which I have shown you should come to your mind, and then you will be able to correlate the anatomy and the question over there.
So Dr. Saktri has asked a question: how ASARP and PSARP are different in steps except for position and incision? Is
So
perineal
they are
body
not
reconstruction?
different. They are not different. Actually, they are not different. If you, they are exactly the same procedure. ASARP and P, it is just looking at the same thing from two different sides. So we tested this. So what we did is that we put the patient in an ASARP position. We just marked the incision, line of incision with a pen, and then turned the patient prone and cut only on that particular line which we had marked, and it was just a PSARP procedure over there. And then we did the reverse. So they are essentially the same procedure. If you're not doing the same procedure in ASARP and PSARP, you are doing something wrong. So you have to cut through the same planes, through the same principle, through the same muscle parts, both in ASARP and PSARP. The only difference being that in the ASARP, the view of posterior vaginal wall is way better as compared to that in PSARP. But again, that is a point of individual preference and surgeon's preference. I mean, the way they have seen, they have got themselves trained, they have got into the particular habit of seeing that kind of mobilization or separation of the rectum from the vaginal wall. Some people are comfortable from PSARP, some people are comfortable from ASARP, but both procedures are essentially the same.
Dr. Gurinder has asked, does age at the time of operation matter with regards to output of surgery?
Yes, definitely. Age wise, it definitely matters. As I said, that lot of things, the cortical evoked responses, they are gone away. The physical training of the boy, of the patient actually is not there if he's not passing. It is the same thing if you do esophagostomy in a TEF patient and you don't operate him for 2 years. 2, 3 years later, if he goes through a esophageal replacement procedure and you ask him to eat, it takes a lot of time to actually come back to the procedure of swallowing. The same happens with the defecation procedure. It's a very coordinated procedure where so many things are happening. So if that thing is not happening in the first year of life or first 2 year of life, then it will have a bearing on the continence system. We have had female patients who were in the age of marriage, and during the age of marriage, after marriage, they came to us because they were infertile, and then it was discovered that they were having anovestibular fistula. So in those female patients, they were 20-22 years old. We did a PSARP or a ASARP procedure, and in those patients, they were having sort of a difficulty. But since in anovestibular fistula, the overall prognosis of continence is good. So if we get to see a patient who is a high ARM patient and not operated in the childhood age, if you do that operation when he is 10 years, 12 years, or even 20 years of age, even after successful surgery, he will have problems because he has not defecated in the early part of his life. And he will definitely have lower continence as compared to his similar counterparts who are operated early in life.
So we have another question on anterior ectopic anus by Dr. Deepak. In anterior ectopic anus, patients are usually more constipated than vestibular fistula. So is there a common wall between the vaginal wall and the ectopic anus?
It's not a common wall, it's actually a fused wall. So there will be a separate tissue of rectum and separate tissue of vaginal wall in these patients. And you just have to develop a plane between the two and trying to not injure either of the two sides, and then you separate. So that is the critical step in these patients. So I would actually, common use of the word common wall is a misnomer. It's not a common wall, it's a fused wall. The same thing happens between the upper pouch of the esophagus and the tracheal side. It's not a common wall, it's a fused wall. So if you dissect in the correct plane, it will lead to separation of the two components.
So we have one final doubt by Dr. Afsal. When normal anal opening tends to be closing on examination, we tend to achieve a dilated opening on PSAR.
Yeah.
So are we losing continence mechanism in attempt to avoid constipation?
So that's a good question. The anal opening in normal individuals is actually a receded opening which goes inside the buttocks or the gluteal cleft, and this is happening because of the contraction of the since it is held in a funnel. The anal opening is held in a funnel, the vertical part of the funnel. The individual, when you examine him, he contracts and pulls the anal opening inside. So that is happening because of the external sphincter. Okay, so but plus external sphincter plus the levator ani muscle. But for the anorectal malformation patients, since they have weak muscles, the weak external sphincters are very poorly developed. The anal opening, whatever anoplasty you are doing, most of the time it is patulous. It will have mucosal prolapse after the procedure because of the lack of the muscle tone in the external anal sphincter complex.
Someone has asked us, is the continence better in LARP or in PSARP?
So again, both of these are essentially the same procedure. Technically, there should not be any difference in continence. Either you do the procedure by LARP or you do the procedure by PSARP. I would actually say that LARP patients are the one who have got a higher pouch, because these are the patients where you will not be able to, you don't want to do from the PSARP route. PSARP patients are usually intermediate to low. The patients who are LARP are actually high ARM patients. So by general notion, the high ARM patients will have poorer prognosis as compared to low and intermediate patients. And that is why I would say that it is not necessary that LARP will have a better prognosis as compared to PSARP. The prognosis will depend on the individual merit of the anatomy which is present in that patient. All you have to do is to correctly place the anorectum either by LARP or by PSARP. So the procedure is essentially the same. The continence will depend on the native disease itself.
Yes, I think we have come to the end of the doubts in the comment section, sir. Thank you so much for clearing all these doubts for patients. Thank you so much for the lecture.
Thank you. Thank you. So we will finish this meeting now.
Yes. Good night.
Good night. Good night, everybody.